people who had extra beats called ectopic beats after a heart attack, and this was very clear, those people were more likely to die. Does this prove that giving people lignocaine reduced the mortality? Guess what happened? The death rates went up. A lot of the stuff that we're told, that doctors are told, the things you talk about, the papers you've read, that data has never been independently verified. It's literally been designed, conducted, and analyzed, and then published by the drug industry, who's got a pathological pursuit to make money.
Years ago, I worked in pharmaceutical sales, and I remember one of the marketing directors just laughed, so we don't want cures, we just want treatments.
One estimate suggests that the third most common cause of death after heart disease and cancer is prescribed medications.
If they enrolled all these obese men in the study, that was kind of problematic.
Medicine is not an exact science. Even science isn't precise, isn't a complete truth.
No,
Einstein taught us that. Stephen Hawking taught us that. You know, Einstein concluded at the end of the day, much of what we'll never know because it's a mystery. Of course, I'm not saying we throw everything out and science doesn't have a role to play. Of course it does. But we have to approach it with a degree of skepticism and uncertainty always.
Welcome back to Balance My Hormones podcast. My guest today is consulting cardiologist and author and public health campaigner, Dr. Asim Malhotra. I said it right. One of the most recognized and most debated voices in medicine over the last decade. But today isn't about the headlines. It's about how he thinks, how he reads evidence, how he changes his mind, and what the rest of us can take away when the experts can't agree. So, Dr. Malhotra, welcome to the show.
Thanks for having me, Mike.
So, why did you become a doctor, and in particular a cardiologist?
I think I was definitely influenced to some degree by the fact that I had two parents who were GPs. So I grew up in a medical family. Although my parents were very open to me pursuing whatever career I wanted to pursue. But I think I was interested in science. I was interested in the human body. I wanted to do something that was a job that was going to give back in some way. And cardiology in particular, I think I got a special interest in, partly because I had an older brother that died of viral myocarditis when I was 11, he was 13, and that had a very big impact on the whole family. So that was my initial interest into cardiology. But of course, on top of that, once I went to medical school, I was fascinated with the heart as an organ. I was curious about how we could actually beat heart disease. We haven't eradicated heart disease, despite the predictions of the Nobel Prize winners in 1985 who discovered the LDL, so-called bad cholesterol receptor, in people with FH, familial hyperlipidemia, genetic condition with very high LDL levels. And they thought that was the primary driver of heart disease. But we didn't, that hasn't happened. We haven't eradicated heart disease, despite the fact that we're prescribing, cholesterol-lowering drugs to hundreds of millions of people globally. So I started to investigate that. And that was also my curiosity as to what really was going on. So that's why I wanted to pursue cardiology.
Interesting. So then, I guess you could say, looking back, you've held certain beliefs earlier in your career. Obviously, you were trained in medical school a certain way. I mean, what have you thought about in the past? And I think you kind of mentioned statins before in your career that you now think is just wrong. I mean, we were talking a little bit earlier about it.
Well, I think it's about accumulation of new evidence as it emerges, but also having a curious mind to think outside the box. And in medical school, you're taught a model which is very much based upon it's a biomedical model where you are thought to think of the human body in separate parts, right? Different organ systems, disease processes that happen, often mainly thought to be mainly genetic, and then they're treated with drugs. So it's a very narrow focus of health. And I think over time, I myself was always interested in lifestyle anyway, because I was a sportsman, active sportsman. I love cooking. I was a foodie. So I think those things had a bit of influence for me to look down other avenues on how we can improve people's health. But one of the areas which really got me down the rabbit hole of cholesterol and heart disease was the fact that I was treating many patients with side effects from statins. And the amount of people I was diagnosing with significant side effects from statins, which usually is things like muscle fatigue, brain fog, all that kind of stuff, was disproportionate to what we were being told as doctors from the guideline bodies and the medical literature in terms of the percentage of side effects. So it was exponentially more I was seeing. And I thought, this doesn't make sense. There's a disconnect here between what was being published in, say, The Lancet, saying that side effects may be 1 in 100 or 1 in 1,000, to me diagnosing 10, 20, maybe 30% of people having side effects. So that's when I started my journey of greater investigation into asking the question about what we are being taught and advised as doctors. Where is that information coming from, really? Who's behind it? How accurate is it? What's being missed?
Yeah. So I think on the statins in particular, I'm personally not a fan of statins. Years ago, one of my doctors wanted to put me on the statins. I was on TRT, cholesterol was a little bit out there. I think genetically I always have a little bit higher levels of cholesterol. But so I don't think statins are great. They're kind of a dirty drug in the sense that they hit a lot of right different pathways. They're not quite specifically targeted. And I think we were talking about earlier about other, so like I talked about I'm on Repatha, and you said I shouldn't be on Repatha. But when they found that the Repatha on the PCSK9 gene, there were people who were deficiency in PCSK9, and they seem to have lower levels of cardiovascular disease. Is that right, or is that?
Yeah.
Okay. So how do you explain that if you modify it?
So this is a very important concept that people need to get to grips with, okay? Let's go back, though. Let's just look at big picture, then home in.
Okay.
So start with the understanding that medicine is not an exact science, not even close.
Yeah.
Okay? It's not like physics or chemistry. It's a social science, it's science of human beings, it's an applied science, it's constantly changing. The human body is dynamic, it's not fixed. Lots of things are going on at the same time. You can identify something that is associated with longevity or less heart disease, for example, but it may be a marker of something else that you have not picked up. So, for example, you identify a biomarker, let's say cholesterol, high cholesterol, okay, that is associated with heart disease, in particular, specifically to people who have very, very high levels of cholesterol, which only affects 1 in 250 people. But the question is, even if you identify a biomarker, which is associated with a disease process, it doesn't mean that lowering or changing that biomarker with a drug will necessarily improve outcomes. I'll give you an example. So going back, and there's lots of other examples, but this is a very interesting one. So several decades ago, and it's still the case, when you have a heart attack, people have an ECG. And it was found that people who had what we call extra beats, called ectopic beats. You may be familiar with this term, right?
Yeah,
extra beats that kick in, like people get a misbeat after a heart attack. And this was very clear, those people were more likely to die. Okay, so they found a drug that suppressed the ectopic beats. Okay, it's called Lignocaine. All right?
Okay.
So they give this drug to people thinking, okay, after the heart attack, we give them this drug, it suppresses the ectopic beats, and therefore, of course, we're going to have less heart attacks. But the only way to show that properly, Mike, to demonstrate that, is you do a randomized trial where you get 2 groups of people. You have the people with the extra beats, right. And then you give the other group who have extra beats a placebo drug. They don't, as in something, a dummy drug. And you follow these people up and you see, does this prove that giving people Lignocaine will stop reduce the mortality? Guess what happened? So it worked in terms of suppressing the extra beats.
Yeah.
The death rates went up.
That's what I thought you were going to say.
So that's so this is a very primitive way of thinking of medicine. People think it's clever. It's not clever at all.
There's a lot.
There's the biomedical model. So what it comes down to, Mike, is what I would call, it's called mechanistic ideology. Okay. So I'll explain what that means. It's the naive belief in the measurability of reality and the misuse and excessive use of data and statistics. But what I'm saying to you is, the biomedical model in medicine actually is the way that drugs are now being approved is dumbing down science, because you're not actually doing a lot of the time the randomized trials to show you've identified a biomarker. Like the same thing's true for LDL cholesterol. So we know people with genetically low LDL cholesterol, this is irrefutable,
right,
get less heart disease. Okay, we know that. But guess what? We've done analysis showing on all the drug trials, looking at PCK9 inhibitors, PSK9 inhibitors, ezetimibe, statins, that when you lower, and this is by the way, this is looking at drug industry sponsored trials that have never been independently verified. So there's another bias here, is that a lot of the stuff that we're told, that doctors are told, the things you talk about, the papers you've read, that data has never been independently verified. It's literally been designed, conducted, and analyzed, and then published by the drug industry, who's got a pathological pursuit to make money.
I was going to say, well, what about
So the
what
truth
about
is,
the
so we don't,
regulators?
so we never know the real true we very rarely know the true benefits and harms of the drugs, which is a scandal. You ask about the regulators, they get most of their money from Big Pharma now.
I know. I was just about to say it's a revolving door. So the same people that are in the pharmaceutical industry revolve back into the regulator, back into pharma. So
not just that, but their funding. So 86% of the funding of the regulator in the UK, MHRA, comes from Big Pharma. 65% of the funding of the FDA in America comes from Big Pharma. So huge, so that you're not getting an independent verification of these results.
Who would the independent verification come from? Would it be
an
accreditation body? Would it be
no? It would just it would be state or government funded. So instead of getting their money from Big Pharma, it would come from the government, and therefore they wouldn't have a bias to try and feed the interests of Big Pharma. It would be for the public good. That's the whole point. So that's where it should come from. And people say, well, where's the money going to come from? Well, these big corporations, I'll be very honest with you, their business model is fraud. They've got trillions, they're making trillions from basically fraud. They're not paying their taxes. The money's there, it's just in the wrong place.
Is it just a big pharma, or is it, because there can be small pharma groups, that are trying to offer maybe some new generic or some new offering.
Yeah. And I think that's fair. And I think, we shouldn't throw the baby out the bathwater. But I think when I talk about the big corporations, they've got so much power that there isn't any checks and balances really anymore, because they are in control of everything.
I mean, years ago, I worked in pharmaceutical sales, and I remember one of the marketing directors just laughed and said, we don't want cures, we just want treatments.
Yeah.
And that seems to be
exactly.
Which is quite cynical, and I guess it's
so for me. And again, it's okay. Listen, we always have to have some humility. We can get things wrong. I try and weigh up evidence on how does it fit with the big picture. Have we got independent analysis? Have we got other data suggesting there may be a different answer here? And that's what I approach with everything I look at in medicine. I look at the patient, I look at the holistic side, I look at conflicts of interest, the biases in the studies, have they been replicated? You've got to put it all together and then make a decision. And then, on top of that, Mike, which is also missing, is giving the patient true informed consent. So, for example, on statins, all right? If you've not had a heart attack, if you haven't got severely obstructive coronary disease, and that means at least a 70% blockage.
Okay.
Right? Your benefit of taking a statin over a 5-year period on industry-sponsored trials that have not been independently verified, right? This is still best case scenario for an individual is 1 in 100. So if we were having a conversation and you're saying, Doc, what should I be doing?
Yeah.
Should I take the statin? Should I take it? By the way, the PCSK9 inhibitors have got no real outcome data at all. But when we did the independent analysis showing all those trials together, there was no benefit at all in preventing cardiovascular events, in any consistent benefit in lowering LDL. The other aspect of it all as well, looking at the big picture, is, anyway, come back to the statin. So I would say to you, Mike, with the uncertainties in the evidence, with the biases, with the fact that it's come from drug industries, with the fact that it's not been independently verified, probably if you don't get side effects, because the people with side effects were taken out of the trials, and then they identified the people who would like to get side effects in the trials that were then done, several other trials that were done later on, and they were then not included in the groups. So you've now got a very biased picture, which does not actually apply to the population as well.
Sure.
But I would say to you, Mike, best case scenario, you take this pill religiously. If you don't get side effects, there's a 1 in 100 chance of preventing having a heart attack or stroke without prolonging your life. You might think, yes, I'll take it. But actually, studies show most people in those situations wouldn't take it. But that's most of the people prescribed statins around the world. So you've got no informed consent going on. And for me, that's not the best way to practice
medicine. If you get a heart attack, it's just automatically given.
There's an extra benefit if you have a heart attack. Yeah. But remember, it's not about lowering cholesterol. I mean, I wrote this in the British Medical Journal 2013. The benefits of statins are independent of lower cholesterol lowering. All the other cholesterol lowering drugs, as far as we know, is just to lower cholesterol. There's no anti-inflammatory, anti-clotting benefits. Statins have that, and that's where the benefit comes from. So for me, with every patient, and by the way, this applies even to people who have got high risk. If I had more than 70% blockages, statins are the only thing that probably have some benefit there, more benefit than harm, probably for most people. But again, I give them the information and say 1 in 39 chance. And many patients, Mike, who've even had heart attacks, do not want to take a statin, and that's decisions to be respected. They'll then come in, well, what's the alternative? Now, most doctors don't have an alternative because we're not taught anything about holistic, evidence-based, dietary interventions, lifestyle. I have learned that myself, in the last several years, and then practice that with my patients. And, and it's remarkable what happens. Get people off their blood pressure pills, improve their cholesterol profile, which is more in keeping with insulin sensitivity.
Right.
Which is actually the main,
statins
worsen.
or worse than that.
Exactly.
Yeah.
So that's what and the other thing about LDL cholesterol is, if you can say, okay, fine, we're not sure whether it's beneficial or not, but it may not do any harm. We know that people with lower LDL levels, okay, are increased risk of cancer and infection. So one of the publications...
But how low? Because it's a U-shaped curve where the damage comes in excessively high or excessively low. It sits somewhere.
Yes, exactly. Absolutely true. Yeah. But what we did find is, when you're over 60, the higher your LDL, we're talking about over 3-4 millimoles per liter, was statistically associated with longer lifespan.
Okay.
In the BMJ, and this is over 60s, they published a paper in 2020 from Denmark looking at 100,000 people over 10 years. What was the optimal level of LDL for lifespan? It was 3.6 millimoles. Right now, you go to your doctor, if your LDL is above 3, you'll get red flag, you'll get fear-mongered in taking cholesterol and drug. It's bad medicine, and we need to get on top of it. We need to resolve it.
Do you think lowering the LDL or just cholesterol in general may have a negative impact on neurotransmitters and mood?
Possibly.
Interesting. Okay.
Yeah, we know that there are cognitive issues that happen with people from statins. One of the mechanisms could be lower cholesterol. And it isn't necessarily very low cholesterol, but it varies from person to person.
Yeah. And the type of cholesterol. I mean, they would talk about the large, fluffy types of LDL.
Yeah, I think that's a bit of a distraction.
And what about ApoB?
Yeah. I think it's all a distraction. I think what a lot of these tests that people get that are extra tests, which give you lots of extra biomarkers, are looking for abnormalities so they can get you on a drug.
Yeah, it's funny. They always say your mum's always right. Mums know best. My mum really is not keen on lowering her LDL at all. And she has quite high LDL. She did calcium score, hope mum doesn't mind, and it was 0. And she's 77, 78.
Yeah.
And 0, though then isn't the worry about the soft plaque that you can't measure with a calcium score.
Yeah, but actually, if you're somebody that's older, then the calcium score of 0 pretty much means you've got no soft plaque either. The soft plaque issue is more with younger people. Okay. So you'll miss it, whereas the calcium score, that is a very, very good correlate of soft plaque anyway.
So, and my mum also has a high LPA, so I think obviously that's genetic. And I'm thinking, well, she's gone this long with high LPA, looks like similar to mine.
Yeah. But you've got to look at, these are population studies where they find associations that are slightly there. For an individual, it may not actually mean very much. And again, they're across the board. They're not corrected for things like triglycerides and HDL.
True.
So for example, when your triglycerides and HDL are normal, for me, LDL is not a risk factor at all for heart disease. Like, it's clearly not a risk factor.
And how important?
So metabolically healthy. In fact, that was also reinforced with a recent study done by Nick Norwitz and Dave Feldman that showed people who are metabolically healthy, they had clearly scans done looking at their coronary arteries, looking even a soft plaque.
Yeah.
There was no ApoB and LDL was not associated with the progression of coronary disease in people who had very high LDL levels who were metabolically healthy. So that's, again, it's just another nail in the coffin.
But what other let's talk about LP-little-A, because there's about 5 different pharmaceutical companies that are vying to get the LP-little-A's, and it almost ties in with, I know there's mRNA, which we'll talk about, because I know you about the vaccines and that technology, but there's also siRNA, which I've known a lot about since the early noughties, 2000, where siRNA is very selective in blocking the output of the gene, the particular protein. And they're looking at lots of techniques using siRNA or RNA interference-like technologies to surgically, block that gene from making LP-little-A. So, I mean, is there harm in that? And
could be. We don't know. But we need outcome data, Mike.
But they've used it in ophthalmology. I mean, I think there's certain things they can do in ophthalmology where they're selectively blocking the siRNA locally in the eye, because again, the difficulty is getting it to the actual tissue. Yeah. And when you're dealing with cholesterol and that's more of a liver
the difference
issue.
Maybe with ophthalmology is you're seeing an instant result, right? Yeah. If it's to do with people's vision. I don't know much about this.
I can't remember if it's a macular degeneration, there's a particular drug that's...
So listen, my approach is if there's no harm and it looks likely that it's going to do some good, fine. Yeah. But of course, you then got to look into issues of cost and everything else.
But what about LPA and other besides just blockage of the arteries? What about things like, was it like something with the aorta? You can get some kind of rupture, or if it may increase the rupture of certain calcification of certain valves. Is that a concern?
I'm not familiar with that data, Mike.
Okay. Okay, because I've read up a lot about the LP-little-a, and I thought it's had a bit of a concern that if you got this,
I think there's an exaggerated fear about LPA, and it's and you're a manifestation of that with the conversation, because clearly that concerns
that
you.
was a concern.
But where does it
for me,
fear in? Who benefits most from that? The drug industry.
That is the one way to look at. Yeah, absolutely.
That's my approach. I've become quite cynical because we're talking about these companies that are psychopathic. I mean, let's be very honest. This is a diagnosis, not being inflammatory here. I'm a root cause person. What's a diagnosis? So the way that these companies make money has been diagnosed by the preeminent psychologist, Robert Hare, who was behind the original definition of psychopathy as psychopathic, okay? Callous unconcern for the safety of others, incapacity to experience guilt, repeated lying and conning others for profit.
Yeah.
So this is what we're dealing with here. Until we get that resolved, right, until we remove that kind of power and tyrannical control they have, we're not going to improve people's health. Because think about, we're supposed to be great modern science. Modern science has caused massive deterioration now in people's health, mental, physical, social. Life expectancy has stalled. It's going backwards in the USA. I mean, think about it for a second.
There's a lot.
If this was great science, why something doesn't make sense?
I'm in agreement. There's something off with the way the medical field works.
And one estimate suggests that the third most common cause of death after heart disease and cancer is prescribed medications. This should be the talking points.
Yeah.
Right? We should, and also what I said earlier, Mike, is very important. Medicine is not an exact science. Even science isn't precise, isn't complete truth. No, Einstein taught us that. Stephen Hawking taught us that. Einstein concluded at the end of the day, much of what we'll never know because is a mystery. That's, of the universe. There are certain things, of course, I'm not saying we throw everything out and science doesn't have a role to play. Of course it does. But we have to approach it with a degree of skepticism and uncertainty always.
So I guess the focus shouldn't be as much then on the LDL. Two other things I want to mention about on this topic on the cardiology side, because I think it's really interesting. And I've been following this a lot. I mean, back in the early noughties, 2003, there was an article about liquid drano for the heart, essentially, in a tip where they created a HDL mimetic to follow the people in some parts of, I think it's called APO Milano B, and they've infused it into patients through IV drip, and they claim that it reduced the atheroma significantly, like it just melted it away. And Pfizer purchased the company, I think it was called Aspirion Therapeutics, and then shelved it. And at the time they were working on boosting HDL, I think it's called torcetrib. It was an HDL boosting one. I think that goes to your point about outcome data. So they clearly elevated HDL, but the outcome data was actually a lot of people died.
There you go.
And then they pulled the study. But I made the similar argument against the regulators because some things, and this is something that we do in the TRT world, there's like enclomiphene. And enclomiphene is not the ideal medication, but sometimes it could be used to give someone a little boost of testosterone.
Right.
It's similar
I think it stimulates the luteinizing hormone, right?
LH and FSH. Yeah. So there is clomiphene that has been approved, but it's usually to induce ovulation in women because it increases the LH and FSH. That's more geared towards a woman, but it's a racemic mixture. So I told the guys yesterday, it's like an Oreo cookie where, you've got the cream in the middle and you got each side. We removed the one side, now you got the cream side with the other bit of the biscuit there. And that's the side that's a good side versus the other side that may cause more side effects in men. So clomiphene, people are still taking it, but we're just removing the...
What was the downside of men?
So the issue was, it does boost testosterone. The FDA, MH, or European Medicines Agency, yes, it does.
And improves fertility, presumably, too.
And it preserves your fertility and it boosts your testosterone. But they said, but we want outcome data. Grip, strength, function. But in testosterone data, and this comes off the back of that cholesterol trial, that all the regulators got a bit funny about not having outcome data.
Yes.
And it's the same reason why on the LPA, I know we talked about that.
So the clomiphene it's not as good as TRT, basically.
No, because
didn't show that.
You're blocking estrogen in the brain, but it did raise the testosterone.
Right.
But they didn't do the subjective feelings. And the reason they didn't is because they went for the trial for diabetics. So they looked at, will this improve diabetes measures and by raising the testosterone and maintaining their fertility? And they enrolled all these obese men in the study. And so that was kind of problematic.
I wonder why they did that, though. That's strange, because normally they know in advance who's like to benefit.
I don't know. With this company, so not all these diabolical pharmaceutical companies are that clever, because they clearly were not clever enough to run a trial to get approval.
Yeah.
And that's we don't have that tool completely available, but fortunately on a named patient basis. I know in your field, like you've been talking about, you had that, your belief on and the data that you presented about the COVID vaccines. And we can talk about that in a minute, but it's quite controversial. I think certain groups have, I think they're talking about, was it the GMC, like the GP groups I was reading were not unhappy with some statements that you made about vaccines and maybe they're leaking to cancer or something. And I wouldn't even go about the GMC because they're a whole tyrannical operation by themselves. But so that's quite controversial. But in the TRT world, testosterone can also be considered controversial. We were just in a hit piece by the Daily Mail. They did it once in 2022, and then they did it again where they did an undercover report who went to a couple of different clinics, including ours, and tried to see, are these people just pushing testosterone on us? So I just want to see what your thoughts are, kind of where you stand about testosterone, because we get the men who are so desperate to have any treatment at all. NHS doesn't recognize this. I've always called endocrinologists mediocre diabetes specialists, because if they're good diabetes specialists, they would recognize the benefits of testosterone and insulin sensitivity. So anyway, I just want to see what your thoughts are.
I mean, listen, first of all, Mike, I'm not an expert on testosterone. From my experience with patients, people who've been taking it, looking at the literature, I think it has a role to play for sure. I think people who have low testosterone or certainly have symptoms with maybe low normal testosterone, and you can educate me on this from your experience too, I think it has a role to play. And I don't see any major downsides. I mean, there has been this controversy about whether it increases risk of prostate cancer, but I think overall, when you look at the overall evidence, I don't think there is any, there's not a clear link. So, and it, obviously for quality of life as a man, for muscle mass, I think there's probably, without the TRT, we know, I think there's an association with testosterone and longevity as well.
Yep.
So I'm not familiar with any major downsides that I'm aware of from testosterone. So I'm curious to see what the criticism that you've received is, because I can't, there's nothing obvious that comes to mind.
Yeah, our clinic in general, they said out of all the clinics in the article, we were the most thorough of doing the consultation and going over blood tests, which is good. But they always put a little jab. They said, because our clinic, in certain rare cases, we're offering enclomiphene because we felt it was safer than the clomiphene that was out there in certain cases when fertility had to be preserved.
Of course, that's the issue. Sorry, just to reiterate, the other issue about testosterone, which is the obvious one,
the fertility.
Which most people worry about, is it affects your fertility.
And there are ways to mitigate.
And if you want to still have children, if you're not bothered, then it probably doesn't matter. But
you still can have children. We have many men that have conceived even without adding in things like HCG to their testosterone. They have been able to conceive in a certain window. Some men might already have poor fertility when they come to us. They may have had a varicocele or the damage to their testes, and therefore, they're not going to have good testosterone or a good sperm count, even with adding HCG or LH and FSH. So it's really quite individual. But we've had lots of success cases of men being able to maintain or regain some level of fertility, and they can stay on testosterone treatment. If you like content like this, do click like and subscribe and hit the notification bell if you want to get our latest updates for when we drop content. It really does mean a lot. And until next time, to your wellness, this is Mike.